Tonight we're going to talk about treating prostate cancer with cryosurgical ablation. We're going to focus upon cryoablative therapy as salvage for patients who've had radiation therapy and failed. Now I'm going to talk to you a little bit about how we figure out where the cancer is in the prostate. This is the ultrasound probe. It's on what we call a stepper unit. This is a gentleman's bottom. The ultrasound probe is in the rectum, and this is the grid. So if we select certain areas within this grid to take biopsies from the prostate, we know where that is and can go back to it at a later date if we choose to. But there is a principle that I'd like you to think about, because it's kind of an unusual word. It's called insignificant cancer. What we've learned is that the cells that make up prostate cancer can send us information if we look at them carefully, and some of those cells aren't very aggressive and don't do much. On the other hand, there's other areas where the cells are very aggressive and can create a significant problem and risk to the patient's well-being. The green areas in this particular case, which is a real biopsy, demonstrate what we would call insignificant cancer. This, on the other hand, is a area of very aggressive cancer. Those of you who've a familiarity with cancer, you know we use what's called the Gleason grading system. And the higher the Gleason score, the higher the aggressiveness of the tumor. So tumors that would fall into this red category would have Gleason scores of 7, 8, 9. Knowing this is meaningful because it's the beginning, as ladies know, of what we call organ preservation therapy. And the most common one that would be known would be breast cancer, lumpectomy, or focal therapy. And that is currently happening in prostate cancer. Imaging probably will be suitable for identifying significant pathology. And the imaging system is magnetic resonance imaging. And we identified in this case a lesion, the only lesion that met the criteria of an index lesion. How many prostate cancer patients who receive radiation therapy have recurrent cancer? Between 20 and 60% of patients, over 50,000 patients. What happens to those patients who have failure with radiation? Well, they receive androgen deprivation therapy or androgen blockade. Hormone therapy is applied to those folks. And it's usually done by the radiation oncologist who has provided the basic radiation therapy. Now, there's some side effects to this hormonal therapy. We have more data available today than we did 10 years ago. And that data basically moves us toward the application of cryosurgery as salvage for failed radiation. But clearly, cryosurgery has a place in treatment of radiation therapy. And that's where we're going with this discussion. Well, the benefits of salvage cryotherapy, most importantly, is curative. And that significant percentage of patients who failed, who are automatically, or it seems that way, put on androgen deprivation therapy and had only the benefit of palliative therapy, now have the potential for curative therapy. And you remember our conservative number was somewhere in the vicinity of 14,000, and a more aggressive number may go as high as 30 or even as high as 50,000, depending on how you analyze those patients who have failed. It has a low side effect profile. This treatment can be given as an outpatient. There's really no major blood loss. Patients get up and go home. And I mentioned briefly focal therapy like lumpectomy. We believe that with our imaging capacities, we'll soon be able to identify where the recurrence is in a patient who's had radiation treatment. And we can treat the problem specifically and leave the rest of the prostate, which likely has been adequately treated by a radiation alone. A Foley catheter is in for less than a week many times. The patients go home the same day, minimal discomfort, and in a short time, the PSA, which was the indicator of problems, is down to an undetectable level. So how do we select patients? Well, the best indicator we have is the PSA, and we'd like to see the PSA at a low number, not because they've had androgen deprivation, but because they now have early diagnosis. And one of my jobs is to share this information with our radiation oncology colleagues, and when they see the PSA rising, instead of automatically going to the androgen deprivation, they consider other options. When you have the opportunity and you then, for instance, do imaging studies like the MRI, when you do biopsies early, you can determine, is there a lot of cancer or a little cancer? Is it on one side or it's on both sides? What's the grade? Is the cancer confined to the prostate, or is it poking out from the prostate? Things of this nature give us clues that we can very successfully treat patients who had radiation therapy and failed, who can once again be a success. But the key is that this type of salvage therapy has to come early in the sequence. And we have to see these patients early and not after they've been treated with hormone deprivation and now their PSA is rising, which may be 2 or 3 years after the real recurrence occurred. And the best predictor for success is PSA. The lower the PSA, the better. That means the earlier the diagnosis, the better. Cryotherapy kills bad cells, whereas the most common treatment, hormone therapy, just takes away the nutrients and sort of puts them into a sleep mode, which most of us would know about as remission. And even when you have really bad actor cells in that group, if they're small and haven't escaped the confines of the prostate, the cryo has the energy, the cold energy, to essentially kill those tough cells, those bad actors. This is roughly 500 patients, and I know it's hard to read. And this is biologically disease-free state. So here we have 500 patients that have disease-free who are salvaged after failure of radiation. So wouldn't it be nice if you had radiation failure and instead of having to take hormone therapy that has its own set of side effects, you could have a one-shot treatment that would give you 5 years of disease-free life. Aaron Katz, who is one of the co-authors of these slides and is at Columbia University in New York, shared this with me. So we have a 10-year survival across the board in their experience with failed radiation therapies that had salvage cryo. Clearly, cryosurgical ablation should be better known for its salvage characteristics for patients who failed radiation therapy.